Welcome, everyone. Thank you for attending this evening's community education event, Managing Pain During an Opioid Overdose Epidemic, What Have We Relearned? So I'm Lily Schlaser. I'm with the All In Clayton Coalition. All In works to keep Clayton youth safe from the effects of substance misuse. We have three coalitions. We have one at Wydown Middle School, one at Clayton High School, and we have our community coalition, which meets the first Tuesday of the month at 4 o'clock. Everyone is welcome to join us in our work. If you would like more information about the All In Coalition, you will have a chance to request that in our post-event survey. So at the end of tonight, I will put a survey link in the chat and I will email it to all of you. And you can give us vital feedback that we need, and you can also request more information on the coalition. As a community initiative, we rely on community members and organizations to help direct and implement our work. Our partnership with Clayton Chamber of Commerce is critical in helping us reach the business sector of our community. So we're really grateful to them for co-sponsoring tonight's event and helping to spread the word about our work. So I'm going to briefly hand it over to Mary Ellen Tobin from the Clayton Chamber of Commerce to say a few words.
Hi, everyone, and welcome. We are so thrilled to have you join us for this very worthwhile program. And we are honored to partner with our good friends at the All In Clayton Coalition. And I hope you will get more involved with them if you haven't already. Opioid epidemic has no boundaries in society. It affects every walk of life. So it's an important topic, and the first step in getting it under control is understanding it. And that's why I'm really excited to hear what's going to be said tonight and share the information with you all. So thank you for joining us. And on behalf of the Clayton Chamber, anytime you have issues about business, call us. That's what we're here to. We're here to help assist in putting together programs like this.
Cool.
Thank you, Lily.
Thanks, Mary Ellen. Appreciate you very much. All right, so on to our main event. First, we will have time for questions at the end of the presentation, but if you want to put questions in the chat as we roll along, our presenter has created ample time for interaction and questions from all of you. So put that stuff in the chat. And we're recording tonight's event. So a lot of folks sign up looking for those recordings. I will share probably tomorrow or Friday, I will share an email out with the recording so you can share that with your networks. So without further ado, Dr. Fred Rottnek is a professor and the director of community medicine at St. Louis University School of Medicine and the program director of St. Louis University Addiction Medicine Fellowship. His clinical practices currently include addiction medicine and correctional health care. He teaches in the School of Medicine, the Physician Assistant Program, the Center for Interprofessional Education and Research, and the School of Law. Board certified in family medicine and addiction medicine, he is the medical director for the Assisted Recovery Centers of America and Juvenile Detention and Family Court for the City of St. Louis. He serves on the boards of St. Louis Regional Health Commission, the Archway Institute, and Alive and Well Communities. Dr. Rottnek is an amazing asset to our community. I am so glad he's here with us tonight and delighted to have him share his expertise and experience on this really important and timely topic. So I'll hand it over to you, Dr. Rottnek.
Thank you so much, Lily, and thank you for the warm welcome, Mary Ellen. This is my second presentation with All In Clayton. I'm a native St. Louisan, grew up in Afton and Sunset Hills and took Metro up to bi-state back in the day, up to Chaminade, went to high school there. So you know all that you need to know about me. My clinical practices are all the sexy stuff, right? Addiction medicine, corrections medicine, homeless health care. In fact, from 2001 to 2016, my Clayton office, as I like to call it, was a St. Louis County jail. And I also took care of the kids at juvenile detention. Now I'm taking care of the kids in the city. But I'll share my screen here, and Lily and I brainstormed what we thought could be a good topic for not only our youth, but also our parents and grandparents and other family members of folks in Clayton. And that's about what do we do now with pain during the opioid overdose epidemic? We know there's a lot going on with that. So we're going to talk a little bit about today about where we are as a nation, as a country. We could talk about the city too, if you want to. Um, but we're also going to talk about how do we reframe taking care, particularly of folks with chronic pain? What are we learning and relearning and getting back to basics before, let's just say, there was a huge oversupply of controlled substances in the United States? We didn't have a lot of these substances prior to 1980s, 1990s, and people lived. Let's talk about what we can do now to kind of reclaim some of the practices that we abandoned in the past. And also, how can those of us on the call who do have access to insurance, what are some things we can think about when we talk to our primary care doc? Again, yeah, jump in there with questions. So started here. Yeah, so results of our session this evening, we're going to talk about the 4 waves of the current opioid overdose epidemic. We're going to talk about rational expectations, resources, and approaches to medication and non-medication pain relief, and some ways to advocate for yourself and your family to manage pain and pain meds as safely as possible. Where are we now? This is a topic, this is a slide that you cannot go to any professional development area in addiction now without seeing. And the CDC put this together. And what it shows is where we are in terms of the opioid epidemic in the United States. And it goes back to a little over 20 years ago, 1999, where we started seeing um, an increase in prescription overdose deaths. And these were things for like hydrocodone, oxycodone. The bad boy that gets all the attention is Oxycontin, because that came out in 1995. What is interesting about all those medications, which we call semi-synthetic opioids, they start off with the same chemical structure as codeine and opium and morphine, but chemists created different attachments to them. So they're called semi-synthetic, synthetic meaning made in the lab. When those medications were originally developed, they were only indicated for use for people in the hospital, for people who had surgeries, for very brief post-surgical use, and for folks with palliative care and end-of-life care. Those were the only indications for use of those common opioids. Now, what happened is that the original manufacturers of these meds who developed them, places like DuPont, they looked at that and said, this is not going to make us a lot of money. There's a very narrow use for these meds. So they sold their patents to these meds to some less reputable manufacturers. And we know the names of those because they're in the news quite a bit now. And through very aggressive marketing, these manufacturers marketed these drugs to family doctors, primary care doctors, and orthopedists for musculoskeletal pain. Now think back, that's not what these were originally manufactured or FDA approved for. But what they said was, you know, these things are safe. We don't need to worry about people getting addicted to things if they're in pain. That's what I was taught in medical school in 1990s. And all of a sudden, people were prescribing these semi-synthetic medications for things like chronic musculoskeletal pain. Things that in the past people would use NSAIDs like ibuprofen or long-acting NSAIDs like naproxen or naproxen or Tylenol or acetaminophen, and heat and cold and things like that. Also during the 90s, there came out something called the pain scale. Some of you might have asked before, what's your pain on a scale of 1 to 10? 10 being the worst pain you can imagine, 1 being barely noticeable. Well, all of a sudden, patient scores and even reimbursements were tied to patients reporting where they were on a pain scale if they were in care for medical conditions. And all of a sudden, the goal became, we got to knock down these pain scores to below 3. And when one of the tools in the tool belt were opioid prescriptions, particularly for people who didn't have other services like PT and OT covered. The only way to get those pain scores down and to help people feel better was to give them an opioid. And I know I'm kind of shortcutting a lot of stuff here, but that was really kind of what a lot of the drivers were, that there became a huge oversupply of prescription opioids in the US, with 5% of the world's population, and we had 80% of controlled substances of the world's population in the US. Now, if you take a look at when things started, as you started seeing a rise in heroin overdose deaths, that occurred around 2010. What accelerated that was, believe it or not, guidance from the federal government, from the CDC, on cutting back prescribing opioids. People were cut off from their prescriptions, sometimes abruptly, and people actually started using heroin and getting stuff off the street. And people might think it's an urban myth that people would start buying stuff on the street if they were cut off from their supply of pain meds, but I saw it repeatedly at the St. Louis County Jail. That was the story I got from my patients, and that's how they ended up there. Now, heroin became very accessible, and we think about Breaking Bad first with heroin and then with synthetic opioids. And now the difference between semi-synthetic and synthetic opioids is synthetic opioids are made in the lab. They're made by scientists and humans. They don't have any chemical correspondence to natural opiates, but they have the same effect on the opioid receptor. So that's why we call them synthetic opioids. Common synthetic opioids that you may have heard about are things like fentanyl, methadone, carfentanil. I know I'm forgetting one that, but anyway, these are things that fentanyl we know is a big problem today, but fentanyl's been used in the OR for decades. But what happened with fentanyl is, Breaking Bad, people were making meth in their trailers, in their backyards, in their basements. Same thing happens now with fentanyl. It's very easy to manufacture this. And a lot of these truly synthetic opioids are still coming out of China and Southeast Asia, usually being transported in through Mexico and then crossing the border there. So what we saw happen now with these synthetic opioids, which we'll talk about in a little bit, why they're so potent. This is what has become the scourge of our region since about 2015. Fentanyl hit the coast first, where usually you'll see drug trafficking happening a lot. What happens in St. Louis, first it was the rivers, then it was the railroads, and now it's the highways, right? We're at the cross path of a lot of people who can come into the area, and it causes a lot of public health issues, everything from human trafficking to STIs to problems with drug trafficking. And another reason is that St. Louis does not have a very strong gang presence. And you might think, well, that's a good thing. And in some ways it is a good thing. But when you're talking about substances being sold on the street, a lot of our peer cities like Indianapolis, Kansas City, Chicago, Memphis, there is a strong gang presence, and the gangs control the drugs. And when gangs control the drugs, gangs want to keep their customers. So I have been told by people who know these things in peer cities that when you buy your dope on the street, it often has a stamp of the gang you bought it from. So there's quality controls put in place. What happens in St. Louis is people will come in with a trunk full of stuff, sell it, and disappear. So there's not that customer base that other cities might have. Okay, so in St. Louis, we saw a real change in the people dying from opioid overdose deaths in 2015 and 2016 to the current day, where almost all the stuff on the street is fentanyl. At first, it was fentanyl contaminated by heroin or heroin contaminated by fentanyl, but now it's fentanyl. And we'll get to the economics of that in a little bit. Now, the fourth slide is where we are now, the fourth wave of the epidemic. And this started around, again, 2015, 2016, nationally, again, at the coast, but it takes a little while for it to permeate the rest of the US. But the fourth wave is now high potency synthetic opioids like fentanyl. Another one called isoterazine is out there. Carfentanil is out there. And either purposely or accidentally, the opioid supply is contaminated by high potency stimulants, high potency methamphetamine, and high potency stimulants. Now, the first thought is, don't these things do different things? Why would somebody want them contaminated? Again, I've been told by people who use drugs and from the literature that by putting the two together, it kind of takes away some of the negative side effects of each of those. Stimulants take some of the negative side effects out of the opioids. Opioids take the edge off the stimulants. But as you can imagine, what this means now is that if people are buying anything off the street in St. Louis, they're putting their lives at risk because people don't know what's in the stuff. We have many people that show up to the emergency room thinking they were buying cocaine and there was fentanyl in it, and they had a fentanyl overdose. You might recall earlier this year, there were 8 or 9 people who died in the same apartment complex on Forest Park Parkway in the city. And they all died because they bought what they thought was methamphetamine from a woman who thought she was selling methamphetamine. There was fentanyl in all of it, and 9 people died within 36 hours. And again, the person selling it thought it was meth. The people buying it thought it was meth, but it had a significant chunk of fentanyl in it, and that's what killed the people. There's other things that are out there too that you probably are hearing about: pill form heroin that hit the playgrounds 10 years ago, where heroin was pressed into molds that made it look like hydrocodone or oxycodone. People are selling stuff on the internet that's saying it's that, but really is mixtures of all this other stuff. And I don't say this to alarm people. You're probably all alarmed enough, but I say it because that's where I think the urgency has to come into the prevention work and the risk and harm reduction work. So we're having conversations, particularly with young people, teens, young adults who might be trying some of this stuff on just let's see what happens. And it's like, this is not your grandparents' heroin. This is not your grandparents', marijuana. This is not your grandparents' opioids. This is a whole different beast out there. So that's why I love working with community groups to kind of get the word out there in different ways. This seems like a lifetime ago. Anything pre-COVID feels like a lifetime ago for me. But this came out in 2015. This was the first public messaging from the CDC about responding to the heroin epidemic, where we were seeing a lot of overdoses from higher potency heroin that existed than the stuff in the 40s and the 50s with all my favorite jazz singers who died from heroin overdoses, usually also with some alcohol in there. The heroin that was coming to the market now was stronger. So the CDC was saying 3-prong attack. 1, prevent people from starting heroin use, reduce heroin addiction by getting people into treatment, and then reverse heroin overdoses by getting naloxone out there or Narcan out there. And those were three tools we continue to use today. The first category is responsible prescribing. I talk a lot to residency programs and peers about how to escalating analgesics, and we'll talk about that today. And then getting people into treatment if they have developed a use disorder. And then also if people have prescription opioids in their house or they're actively using any opioids, they should have naloxone or Narcan around to help reverse an overdose. So let's zip forward to 2020 and talk about what has complicated pain treatment in today's world. And also feel free to slow me down if I go over too much. I tend to be somebody who tries to get people interested in stuff, and then I'll give you lots of resources to learn more. So I kind of am like a physician cheerleader, okay, to get people interested. So where are we in treatment today? Continued unrealistic messaging is about pain. If any of you have had a surgery, if any of you have had a fracture, hopefully you have not had physicians say, don't worry about the pain, we'll take care of that. But I've heard that say way too many times. You have a surgery, somebody's put a scalpel into your skin and moved things around inside and closed you back up. That is not a normal human experience. You're going to have some pain, okay? Some folks on the call, you might be like me, and every once in a while you make that noise getting out of the chair, right? Something's hurting. That knee, that hip, that's something. But pain is part of the human experience. And too often in the US, we've gotten into this thing where, oh, pain isn't normal. No, pain is normal. We don't want to live with it if we don't have to. But pain is a normal part of getting older. And now that people are living to their 80s and 90s, you live longer, you're going to have pain. So many physicians have overcorrected. A lot of physicians, and I think this is unethical as well, have just said, I'm not going to prescribe opioids anymore. Well, what happens to your patients who have been started on opioids and have taken them maybe for decades for pain? Those patients end up going to federally qualified health centers or academic practices. And I just started this week having a conversation with my department chair about how can we start running a pain clinic with our SSM partners for the people who have been started on opioids for decades, and either they're unable or unwilling to taper off of the opioids. Well, how do we look at providing care for them? Because we can't abandon them, because they'll end up buying stuff off the street and we're driving them into the arms of fentanyl. So how do we work with the resources we have to reduce harms associated with opioids? And our chair is funny because she goes, nobody at SSM wants to talk about it because it's a hot potato. I said, well, fortunately, you've got a jail doctor here who never had the luxury of not touching a hot potato. So let's figure it out, because we have a generation of people that got dependent on opioids because physicians and healthcare providers prescribe them. We can't abandon them. Let's see how we can do better by everybody. And also, docs get worn out by this work too. Let's figure out a way that we can have some win-wins here. Illicit drugs are everywhere. When I was growing up, we didn't have hydrocodone everywhere. We didn't have Vicodin and Percocet and Oxy everywhere. It's everywhere now. And you can use your smartphone, and you can get them at Deerberg's in the parking lot. You can get them at the library. You can get them at Plaza Frontenac. So you don't have to go to the bad part of town. Okay. And again, we've realized that we have to do a much better job educating our patients and our public in this. So let's talk about some rational expectations, resources, and approaches to medication and non-medication pain relief. And here's things that I talk about a lot with our med students, our residents, our attending physicians. And that's why I talked about from a prescribing provider, because I use that term a lot because it means physicians, PAs, physician assistants, nurse practitioners. My primary care is a nurse practitioner. So how do we talk about managing pain and avoiding damage? Because we all talk about first do no harm. So reframing the conversation from pain to function is one thing I like to talk about. Pain scales are useful if you have a specific intervention and you want to know if the pain's getting better or worse. Otherwise, they're not very helpful because it's all subjective, right? It's your experience of pain. What I like to try to get this generation of healthcare providers to do is instead have a conversation with your patient on what pain is getting in the way of. Focus on function. For example, if somebody really likes to garden, but their knees hurt so they can't get down and do the work, well, I work with occupational therapy. Talk about getting long handled devices, buying a hoe, buying a shovel with a long handle, buying a little rolly cart that maybe you can sit on if you can't kneel, right? Getting pads that you can kneel on to work in the garden. Another thing is, how do you manage getting up from the floor? If you have grandchildren you want to play with, you want to get back up off the floor at some point. So finding out those maneuvers, those exercises, how do you focus on what you want to do with that function? Many of us on our insurance plan, we have access to physical therapists who can do a better physical exam on function in 5 minutes than most docs can do in 30. Occupational therapists who are wonderful about assistive devices. If people have pain in certain areas or problems, everything from how do you have a fork or a spoon with a bigger handle, things like that. They're great in problem solving. More and more insurance plans are covering things like therapeutic massage, acupuncture, alternative medicine. Take a look to see what's on your plan. Be an advocate for yourself to see what's covered, what's not. I know this isn't easy. Believe me, SluCare's practice was bought by SSM. I had to choose a new healthcare provider, and I'm thinking, this is so hard to read, and we expect our patients to know how to do this. And here I am with a 32nd grade health literacy level or something, and I don't understand it. So the other thing too, track changes in progress towards goals. We can do that with our own health as well. What are things that we can do? Have I been able to go on, how long can I walk around the block before pain becomes a problem? What are some exercises I can do before pain becomes a problem? What are some things I want to do and enjoy without pain getting in the way? And how can I track my own baby steps towards that? Because sometimes the iceberg looks too big. And if we can break it down into steps, it makes things more accessible. Now, again, here's something that I teach my medical students and residents on responsible prescribing. And I tell you this too, because you can come into your provider's office with some of these tools in hand as well. In the US, we have a pill for everything. I remember the first time I had a 12-year-old come into juvenile detention and asked me for a sleeper. And it told me a lot about his experience in life so far if he knew to ask for a sleeper, right? But it's always better if we don't need a medication. Because guess what? Medications change our bodies. That's why we take them. Sometimes we get surprised when we have side effects, but you just took a pill in your body to change something. Okay. Everything has a side effect. There's very few things that don't. Topical treatments are better than oral treatments. Topical treatments are local. If you can get a cream, if you can get a patch, if you can get something that, if you have joint pain and you can get something there, always better than taking a pill that goes through your whole system. Some of you on the call might remember Bengay. I remember my grandma always had it in her house coat pocket, and she always smelled of Bengay. Okay. There's good stuff with tiger balms, right? There's a lot of topical things that increase blood flow to a given area. And then go to local and minimally invasive medications, trigger joint injections, joint injections, hip injections, neck injections, ankle injections. My dad goes in every 3 months for a steroid injection because he broke the big bone in both of his feet falling off of ladders when he was a carpenter again in his 60s. Does a wonderful job. It keeps the medication local, and it keeps it the kind of a depot formulation. It keeps the medication in the area to do most of the work. And then there can be more invasive things like spinal injections, epidural injections. Notice it's not till we get down to number 5 that we start talking about pills and tablets. Okay. And here's the reason why. If you don't need a med, don't take a med. If you need something, keep it local if possible, so that the medication is working on your source of pain. Then you want to start talking about something that you have to ingest, has to get metabolized, has to go through your whole circulatory system, has to get broken down by either your liver or your kidneys, and then you pee it out, right? You can kind of see that this is not what we're used to hearing recently. So this is something that I really try to have our trainees learn, because not everybody has access to all these. I can tell you, if you have Medicaid or you're uninsured, you're not going to have a lot of access to a lot of topical treatments, a lot of injection treatments, but all of our family medicine residents learn how to do joint injections. Their clinic is at a federally qualified health center in South St. Louis. So we're trying to get some of this back into the game. Now let's talk about our oral analgesics. And I remember way back when I was a baby doctor, senior med student, doing my last rotation before starting my family medicine residency at Deaconess, which is now Prairie for the Zoo, right at 40 and Hampton. I remember sitting down with our clinical pharmacist, which was the first time I worked with a clinical pharmacist. And I said, Dr. Burke, there are so many pain meds out there. How do I come up with a responsible way of knowing what I need to know to do the right pain med? Well, I have been teaching this category from Jack Burke for, God, how many years it's now? 27 years. And this is what we do. And this is what we talk about today. And it's more important than ever, because all the new CDC guidelines, you'd think they would have taken Jack Burke's class on pain management. Start off with the over-the-counter stuff, acetaminophen and non-steroidals. Acetaminophen or Tylenol. Non-steroidals are things like ibuprofen. Generics are always fine. Sometimes the brand names have coated stuff. If you have GI problems, the coated tabs sometimes protect your stomach a little bit more. If your pain isn't controlled, then consider going up to long-acting NSAIDs. These are the common generic one is naproxen. Naproxen lasts about 12 hours for most people. But there's also long-acting prescription NSAIDs, like Daypro, like Feldene, like other ones. There are lots of generics that last, one tablet will last 24 hours. People who want to be careful with these are people who have kidney problems, because NSAIDs are metabolized through your kidneys. Acetaminophen or Tylenol is metabolized by your liver. You never want to do more than 3 grams a day of Tylenol. But the thing too with NSAIDs and Tylenol, those of you who have raised little ones know that you can alternate these if you have babies and children with fever. Pediatricians and family docs do a good job of reminding parents you can alternate these. And I tell people that all the time. With pain, with fever, with other problems, you can do an NSAID at hour 1, hour 6, do Tylenol, hour 12, do your NSAID again. So you can alternate these things for pain as well as for fever. Then if those, you have to escalate care, then you can go up to what the class is called psychotropics or neurological agents, things like gabapentin. Pregabalin is also known as Lyrica. Duloxetine is a medication which was originally used for seizures and then pain, also is used for depression. It's also Cymbalta is a brand name. And then tricyclic antidepressants, you might have heard of, like amitriptyline, Desiril. There's a whole, been around for decades. All of these medications work usually at lower doses and often for neuropathic pain, pain related to nerve damage. Think about sciatica, think about pain related to diabetes. And the really nice thing about all of these pain meds, you can mix and match. You're on gabapentin, and then you can still use NSAIDs, you can still use Tylenol. So you can still use these different things because they all work slightly differently pharmacologically. My dad, when he broke his ankle, his heels, he got started on gabapentin and duloxetine for chronic pain and for neuropathic pain because it affects the nerves. Well, what was a wonder of that is my dad was what was we typically would have called male pattern depression. We used to say female pattern depression was women would have tearful episodes, women would isolate, women might uh, have more negative symptoms in terms of non-engaging, whereas male pattern depression, and we don't teach it quite this way anymore, but male to pattern depression, I used to call it pissy depression. If men were depressed, they would often lash out and be angry at people. They would often be couch potatoes. They'd be grumpy. Well, my dad had his long-term depression magically cured in the 60s when he got started on 2 medications for his ankle pain that also treated his depression. Dad was a new man. It was a little late for us 3 siblings, but it was great for him. And it's great that he has done much better now in his life, now that he's in his late 80s and he's still on these medications. So there's dual purpose for some of these. Notice we haven't talked about any addictive medications yet. That's when we get to opioids. Short-term opioids are preferred over long-term opioids. And the rule here is start low and go slow. Long-acting opioids often accumulate in the system and can create more problems with dependence. When we have people on opioids now, we usually means they have some of these other regimens involved already, and we're only using opioids when we need to. We're also getting back to a limited supply of opioids rather than just getting people on what I did as a med student in 1993, and I tell this to all my students. Our job, because we were still on a paper chart back then, and all the students think, I'm as old as the dinosaurs, but we were on paper charting. And our role as third-year med students was to write Percocet, 1 to 2 tablets every 4 to 6 hours as needed for pain, number 160 with 2 refills. And that was practically every surgical procedure we did. And now we do things like, okay, 7 day supply. That is what the guidelines are for any new complaint of pain, including a surgical procedure, to send people home on no more than a 7-day supply of opioids. Other things can be included, and then if you go to the ER, no more than a 3-day supply. And the goal is to get people back to their primary and not to get them, letting them create a dependence on the opioid, which can occur as quickly as 7 to 10 days. These are things we have learned in recent years. So now when people get discharged, they get sent home on, tends to be a 7 to 10 day supply. They may get refills of that, but that's with an assessment. It's with a phone call. It's with a follow-up visit. It's with an assessment to see how you're doing. And the goal is not to create that tolerance that can occur with abusable substances. Okay, now let's talk a little bit about how to advocate for yourself and your family to manage pain when you go into the doctor's office. I feel kind of subversive doing this, but this is something that some of our medical students have done service projects working with middle school and high school kids on how to prepare for a doctor's visit, how to talk to your doctor about things that are important to you, and how to use your words, how to talk about things that are important. Well, sometimes we need refreshers on how to use our words, even as adults, when we go into the doc. Here are things that I train up med students and residents to ask questions, but these are ways you can create a history so you are ready to talk to your prescribing provider about your pain. Because these are things that ideally your provider should be asking you. And you can see a laundry list of questions, and you'll have this list in this presentation. But these are things that ideally your provider is taking the time to ask you. Everything from when did it start? What do you think is causing the pain? That's my favorite question that enough people aren't asking yet. I always say, ask your patient what they think is causing the pain, because you will get a lot of answers you will never think of. And you'll get an insight into their spiritual beliefs. You'll get an insight into what they associate pain with. You'll get an insight into their day-to-day activities. What causes the pain? What makes it better or worse? How often do you feel it? What are associated features? A lot of people have pain due to unaddressed trauma in their life, sexual, physical, emotional abuse. In the US, it's not okay to necessarily talk about that, but it's okay to talk about back pain, right? It's okay to talk about your stomach hurts. It's okay to talk about headaches. But sometimes, rather than talking about the fact that we have trauma in our past, we have co-occurring mental illness, depression, anxiety, we'll frame it as something else. So sometimes it's helpful to tell your doc, you know, I do have a history of abuse as a child, an abusive relationship. I don't know if that's causing or making this pain worse, but it's good to bring that up. What have you tried before? Anybody with chronic pain has tried something, right? Hot, cold, couple highballs before bedtime to help you fall asleep faster. Things like coming home from work, doing that. I was raised in a household with my parents were both heavy drinkers. My mom had horrible scoliosis. I didn't know this until I was in medical school. She got addicted to Darvocet. Remember when that was on the market, Darvon and Darvocet? And back when you could get bottles of pills that were that big that you kept on your Lazy Susan in the kitchen, okay? Mom took Darvocet until that got pulled off the market. And then she started with Scotch and Rusty Nails. That was her drink of choice. And I tried to get her to go to look for interventions for the back pain, never did it. Ended up dying not of alcoholism, but alcohol was she was misusing that until she died of breast cancer. But there's a lot of complexities go into that. So if you can tell a story that gives your prescribing provider more help, that will help them be more effective working with you too. Know your goals. Like we talked about earlier, if there's something you know you want to be able to do that you can't do because pain gets in the way, bring that up. That gives your provider more to work with. Because yeah, getting rid of pain is nice if you can do it. Helping your patient have the kind of activity in their life they want to have, everybody wins. So think about things that you want to do. Do pain conditions run in the family? Does sciatica run in the family? Scoliosis run in the family? Do you have any concerns about pain meds? Do you personally have any problems with substance use? It is amazing how many of the people I work with in my clinical site at ARCA who are peer workers who have lived experience with substance use disorder. They're in recovery. They're part of the treatment team. They do motivational interviewing. They educate providers about what it's like to have substance use disorders. They tell me all the time, I went to an urgent care and because I broke my arm. And I told them I didn't want opioids because I have a problem with substances, but I'd like any non-addictive stuff that will help. And they still prescribe opioids. So we have work to do. Lots of opportunities for improvement is how I like to say it. And explore non-medication options. If you know what your insurance covers and you know you got chronic pain, if you've not been to a physical therapist, ask if you can go. Ask them, write a referral to physical therapy for this neck pain to see if there are exercises or traction or hot and cold that you can do. Those are folks that will do a great job. Let people know that you might not want the easiest thing, which is writing for a prescription for an opioid. Instead, You want to learn exercises. You want to do work. You want to learn the work. You want to learn other modalities that might be other ways to address pain. These are different populations. I always tell my students and residents, if you're working in these areas, there's certain pain conditions which show up. So of course, pregnancy, labor, delivery, breastfeeding, that's one of the biggies. We talked a little bit about trauma. People who are immigrants, who are refugees, often have PTSD or trauma related to their life experience. There's certain pain with HIV/AIDS. There's certain pain with sickle cell. There's certain pain with cancers. A lot of people now can be successfully treated for either soft tissue cancer, bone cancer, or blood-related cancers, but there's specific pain syndromes that you want to manage during the treatment and after the treatment. So these are all things we just have to get much more sophisticated in the language and our vocabulary around pain. Advocate for your pain. If you don't want opioids, say so. Just because you got a tooth pulled doesn't mean you necessarily need a prescription for hydrocodone if you don't want it. My dentist is very funny. He's a young guy and he knows what I do. So he likes to hear about my adventures. And when I go to other parts of the country and do trainings and such, and he goes, yeah, it's amazing how many people come in now and say, I don't want a prescription for that because that's an opioid and I could get addicted. And he goes, I just pulled a tooth out of your head. Are you sure? And so they have a conversation, but then they also talk about let's talk about ice and cold packs, and let's talk about ibuprofen, and maybe I can write for a long acting non-steroidal that's not addictive that might give you better pain control. So he's learned to ask better questions. If you have opioids at home for whatever reason, ask for naloxone, the nasal spray or the injection, which in case anybody gets into your opioids. We know there's a lot of diversion. A lot of teenagers start on grandma's or auntie's leftover Percocets because we never want to get rid of our opioids, right? We keep them in the medicine cabinet, but we know that a lot of young people get started on opioids from leftover prescriptions. One, get rid of that, which I know Lily can talk to you about, getting doTERRA bags, drug disposal bags. That get rid of it safely and in an eco-friendly way, but also have the reversal agent at home just in case something happens. Use a lockbox. It sounds like that's overkill, but I tell people if you have controlled substances at home, have a lockbox so that little people, teenagers, your dog, don't get into it, whether we're talking about opioids or we're talking about edibles with cannabis, right? Lock it up. And use a drug deactivation disposal system. There's a lot of those online. You can order them from Amazon. I'm trying to see where I have a bag here somewhere. I don't know where it went, but doTERRA, DETERRA. There you go. Thank you. That disposes, it breaks down, even the envelope breaks down naturally. I'm working on some opioid litigation work with what to do with settlement funds, and I'm spreading doTERRA bags and naloxone all over the place. So those were the topics today. Briefly, I want to give you a few resources where you can do some more research on your own. These are my go-to places that have very patient and public-friendly language and documents with the National Institute on Drug Abuse. This is under NIH, the National Institutes of Health. You can tell it's been around a long time because it doesn't have a very friendly title, but they're not going to change it now. The CDC has wonderful public facing information on pretty much every drug you can think about. Also how to talk to young people about drug use and prevention. And then the American Academy of Family Physicians, I always refer people to our literature because we're family doctors, we're not fancy people. We write things in a way that can be understood. These are my two guardian angels. I always say if we have guardian angels, they have 4 legs and fur. And if I were at home tonight where I usually would do an evening presentation, either Michelle or Barack would be Zoom bombing the screen, sitting in front of me and staring into the camera like it's their meeting. I now have requests for meetings. They want me to do Zoom meetings or Zoom talks at home so they can see the cats. Here's my information. Here's the page to our Addiction Medicine Fellowship in St. Louis. We're still the only program in Missouri. We're in our 4th year. I was just telling Lily, our fellow this year, I've been so fortunate. All my fellows so far are mid-career docs who have come back for a year of training to add this set of tools to their tool belt. This year, Cheryl Liss and her husband, Paul, different last name, forgot what it is. They have twins who are freshmen at Clayton High because Cheryl grew up here and is from the Liss family, LYSS, or like legacy family, Clayton High people. Her dad's also a pediatrician. After she finished residency in peds, she went to the CDC to do a preventive medicine fellowship, ended up staying there for 23 years, and then wanted time to retire. She looked up where fellowships are. They don't have one in Atlanta. We worked for a year, communicated, met, and now she is in her 4th rotation, and I'm trying to keep her on its faculty to be part of our workforce here. But she's somebody that I know will want to meet Lily and be very invested in getting to know folks in Clayton, because that's where her family has generations of roots. So that's me. I'm always happy to come back, but we've got time for questions. If you have questions, and I see there's a couple things in the chat box. Okay. How do physicians and pharmacies cross-check prescriptions? Is it actually possible to doctor jump? Yes, there is. And let me tell you, until the last legislative session, this current one, okay, let me think. Where are we? We're in October. The current session, we were still the only state in the country not to have a prescription database monitoring program. And let me tell you what that is. That is a database that each state sets up the way they want it. Makes me crazy because some things I think we could do nationally, but you know, whatever. Every state sets up their own PDMP. They identify what controlled substances they want to be reported there, and the information from pharmacies will go into this database. So what that means is if Fred Rottnek looks up John Wayne's name, date of birth in the PDMP, it will tell me what prescriptions John Wayne has for the medications identified, say hydrocodone, Vicodin, buprenorphine, Valium, and what pharmacy he's getting them at. Okay. Different states are different on how they use their PDMP. Some states it's mandatory that before you prescribe a controlled substance, you have to check the PDMP to see if your patient's getting controlled substance already and where they're getting them. Now, what I tell people is that a flag in a PDMP, like somebody's going to 3 doctors for their opioids, is a blunt tool. It's a help me understand kind of question. Just like a positive drug screen is a help me understand kind of question. It's not a reason to fire a patient, to abuse a patient, or to chastise a patient. It's a chance to have a conversation to say, hey, I just checked your name and it showed that you got 3 different opioids this month. Well, one of them might have been at a dentist. One of them might have been at an ER. Granted, you would have wanted your patient to tell you that already anyway. But the other thing too is a lot of people who are trafficked for sex or other reasons are trafficked to go to doctors, to doctor shop to get pills that the trafficker will sell and make a lot of money for that. So sometimes it's a red flag for intimate partner violence. Sometimes it's a red flag for other things, but it's a tool. It can be a useful tool. What I don't like about the PDMPs that incorporate artificial intelligence into databases that they may have access to that are public databases. For example, I look up John Wayne's, and if in Missouri, that fortunately we do not have this, and hopefully we won't add this to our database. If the database is given the authority, it can look at my DYS records. Have I ever lost custody of my children? It can look at my credit scores. It can look at whether or not I've ever declared bankruptcy. It can look at whether or not I've ever been incarcerated. And the wonders of artificial intelligence, garbage in, garbage out, so not too much intelligence. It will come up with a risk score for me to divert controlled substances. Now, who's that going to hurt the most? The same populations who have been hurt the most by institutional racism and bad public policy. It's going to hurt people of color more. It's going to hurt people who have more problems with their finances. It's going to hurt people who have less wealth, less resources, less insurance. So there's good and bad about these databases, and I probably just told you more than you wanted to know, but they can be helpful, but they don't take the place of a conversation or clinical decision making.
Very good. Okay, I think that's it on our questions, but I did want to remind everybody that October 29th is DEA Take Back Day. So if you do have prescriptions to get rid of, maybe more than fits in a doTERRA bag, go to your local police precinct on October 29th and get rid of all those things that are in your medicine cabinet. You can fill out the survey and request a doTERRA bag for me. Melody Quinn with Crush says she's got lots. Melody, I actually need some, so I'll talk to you about that. I'm using the rest of mine tomorrow at a Clayton Chamber of Commerce event where we're going to be giving away doTERRA bags. Thank you, Mary Ellen. So here in the chat is a link to our survey. If you all would be so kind as to fill that out and give us a little bit of feedback, we really appreciate that. Any further questions for Dr. Rottnek before we wrap things up?
I just wanted to add something. The Clayton Police Department also has 24/7 where you can drop off drugs in a box and the DEA will destroy them. So if you don't get a tear bag tomorrow at our Shred Fest event, stop by the Clayton Police Department. If you're not in Clayton, I would recommend calling your St. Louis County Police or whatever area you're in, because many of them have it year round. So
and most fire
don't have to hold on to those drugs.
Yeah. Most fire departments will take them in too. But this is a cool thing that when you ask what you can do as an individual to contribute to making the world a safer place, tell people to get rid of their abusable substances. Tell them to get rid of their controlled substances. Because a lot of people don't know, or they'll like do the crazy stuff and flush it in the toilet. We do not need this stuff more in our water tables. So just tell people, get rid of that stuff. Clean out your medicine cabinet. It's a really simple thing that you can do really, really good public service education with. Okay.
Absolutely.
Well, it was a pleasure meeting all of you, and thank you for your questions. Thank you for the head nodders. I love having the head nodding. And I hate to miss an eye roll, so I'm glad there were people on the camera too.